assessment of the post-traumatic cervical patient has got to be graduated, especially in the first 4 to 6 weeks. It's been demonstrated clinically that if the patient can survive for about 6 weeks after damaging the vertebral artery, then the chances are that they will survive the injury itself. That any real damage that's going to occur as a result of forceful movement or head positioning on top of the injured artery will occur within that 6 weeks. So that first 6 weeks is a critical period, and ideally stressing the artery should be avoided during that period. Now, if the patient has more than about 40 degrees of rotation, the chances are that they're stressing the artery themselves. That would be an indication for you to do a reasonable series of tests for the artery. Similarly, if you're contemplating a treatment that will threaten the artery, then in those cases the artery should also be tested. But with the post-traumatic patient, it's becoming clearer that the less you do to these people, certainly manually in the first 3-4 weeks of the injury, the better they tend to do. And this is consistent with any inflammatory condition. Let the inflammation settle down. So ideally, we'll keep away from stressing the arteries for the first 4 to 6 weeks. That doesn't mean to say that we can't look for problems, though, but we do it in a much more least stressful way. First of all, the history. If we're looking at innocuous components to this examination, the history has got to be the least noxious. So we're looking for any symptoms that are cardinal. That is, that we can say definitely that these are central nervous system signs and symptoms, or at least definitely enough for us to send it back to the patient. So these would include things such as nystagmus, Wallenberg syndrome, hemiparesis, ipsilateral Horner's, ipsilateral facial anesthesia, anything that could be central nervous. Secondly, we're looking for non-cardinal signs and symptoms in the history. Dizziness has been reported in almost every case of vertebrobasilar ischemia, but of course dizziness is usually benign. Nausea, vomiting, anything along those lines where it may be central nervous in origin, but on the other hand it may not. And by taking time with the history, we can get some idea of what's happening. For example, if they are complaining of dizziness, what type of dizziness is it? Is it vertigo, where there's actually an illusion of movement, or is it lightheadedness or giddiness or unsteadiness? When does it come on? Is it related to turning their heads, or might it be related to when they take their medication? Because there's something like 400 medications listed as having dizziness and adverse effect. When did the dizziness start? Immediately after the accident or sometime later? If it's immediately, then they've probably damaged the vestibular system. If it's delayed, it could be central nervous, the bleeding taking a little while to come on, or it could be articular, the joint inflammation taking a little while to come on. So from the history, if we're getting the patient relating cardinal symptoms, then basically we can stop the testing and get it back to the physician. Otherwise, we need to carry on testing. And in order to keep this not innocuous again, we want to do tests that do not really stress the artery. Well, one of the tests we can do is to take the carotid pulse. And it's been demonstrated experimentally that occlusion of the vertebral artery will increase the flow rate through the ipsilateral carotid by about 1.5 times and the contralateral carotid by about 2.5 times. So we'll take the pulse in the neutral position to get a baseline on its strength, and then we'll also take it when we do start positioning the head in various positions where we're trying to actually occlude the artery to see if the pulse strength increases. Not the rate, but the strength of the pulse. Following that, we can look for neurological cranial nerve signs, and we can try to induce these signs with various tests.